Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. Now we'll start the second session of this webinar. The second session will be about spondyloarthropathy, and our chairperson for this session is Professor Suzanne Attar. Professor Suzanne is my sister actually and best friend. She's a professor and consultant rheumatology at Department of Internal Medicine at King Abdulaziz University Hospital. She is a well-known as a speaker. She got a lot of publication. She is board certified at Royal College of Physicians and Surgery in Canada and fellow of American College of Rheumatology. Professor Attar held numerous other roles as a member in the Zaidi chair, also member in Society for Rheumatology. She published many researches in multiple national and international journals. Without having a delay, I will give her the microphone to start the session. Welcome, Dr. Suzanne.
شكرا. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله سيدنا محمد أشرف الأنبياء والمرسلين. It's my pleasure to present the second session of the best of the EULAR. Now, we're going to have a very fruitful session for one simple reason. There's going to be so much information. By the end of this session, you're going to consolidate your knowledge and you're going to know on what base you're treating your patient. So please grab your coffee, grab your refreshment water, and we're going to start ahead with our speakers. We have two great speakers. The first speaker is Dr. Mohammed Badawi. Dr. Mohammed Badawi is an assistant professor at King Saud University. He's the formal head, he's the head of the department of the rheumatology unit at the King Saud University Hospital. He's a member of the Assas Society as well as the research group for psoriatic arthritis and psoriasis as well. He had many publications and he did his fellowship in Toronto, Canada. Dr. Mohammed Badawi, the mic is yours.
Thank you very much, Prof. Suzanne. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Many thanks for being with us today, and special thanks for Saudi Society of Rheumatology in the name of Dr. Hanan Rais and Dr. Khalid Al-Anidi for this great organization and preparation. So it's my pleasure today to be with you and discussing the updates or more recently published data on the EULAR. Actually, as you remember, the last recommendation and guidelines was published in 2019, the ACR. So we do not expect a lot of recommendation or guidelines in 2020 EULAR, but we have found a lot of good and interesting papers, poster, and trials. So the major question now we have in spondyloarthritis, after we are reaching the area of full remission, should we go for tapering the dose of biologics or stop it or keep it as it is? This study about etanercept withdrawal, it's very good.
Dr. Mohammed, could you please share your screen? You didn't share your screen. We don't see your slides.
Okay, so do you see the screen?
Yes.
Thank you so much. Yes, you can continue.
Sure. So this is first trial, which is etanercept withdrawal and retreatment. It's EMBARK and re-EMBARK trials. If you look to the background of the continuation or discontinuation of the biologics, in 2016, we can see here the recommendation of the ESAS EULAR to sustain, if the patient sustained remission, we have to taper down the biologics. But in 2019, the ACR guidelines came in the opposite way. They said in adult receiving treatment with biologic, we conditionally recommend against tapering the biologic. And if you look here, the evidence, level of evidence is very low. So the objectives of this study to estimate the proportion of the patient with non-radiographic spondyloarthritis who flared within 40 weeks of etanercept withdrawal. So I will not go through this slide, but if you look to this study design, it is very well designed study and looking for the period 1, starting from day 1 until week 24, all the patient will receive the full dose and standard dose of Embrel. At the week 24, if the patient sustained a remission defined by ASDAS CRP less than 1.3, then the patient will go for period number 2. As you see here, the patient will be off etanercept totally. So there is no tapering of the dose. The patient will have full stopping of the medication. The period number 3, if the patient developed flare during the period number 2, the patient will start period number 3 and he will be back for the full dose of methotrexate. So during this or out of this study, we can see the efficacy of stopping the Enbrel. And the question we have it usually in our clinic, if we stop the biologic and we get it back, can we get the full or the usual or the previous response we get it before stopping the biologic? So I will jump to the result. If you look here to result, after about 60% of the patient, after starting the Enbrel, at the week 24, 60% of the patient reach the area of full remission. And this is very good result. At the week 24, the patient with full remission, they stopped the Enbrel totally. And we can see out of this chart on the right side how the patient flared slowly. Just after 4 weeks of stopping the Enbrel, about 22% of the patient flared. Then at the week 32, 37%. By the end of the 64 weeks or 40 weeks, the patient, about 75% of the patient flared again after stopping the Enbrel. So the other question is, after we are resuming now the Enbrel, we know that at the period 2, about 75% of the patient of Enbrel flared back again. So after reintroducing the Enbrel, only we got about 62% of the patient, they regained the efficacy of the Enbrel and they went again for full remission. So summarizing this study, that 60% of the patient will get the full remission, but after stopping the Enbrel, about 75% of the patient again flared, and after reintroducing the Enbrel within period number 3, only 62% of the patient regained the efficacy of the Enbrel. So the conclusion here, for the patient with non-radiographic axial spondyloarthritis who achieved inactive disease with etanercept, then discontinued the medication, 1 quarter only maintained the free or the remission status for 40 weeks, and about 75% they flared again. And after we restarting the etanercept, it's only 60% of the patient they regained their previous remission. So what we conclude out of this study, stopping the biologic after reaching the area of full remission is not an option so far on spondyloarthritis, and there is no evidence supporting the idea of stopping the biologic. So this another study is going with the same concept. After we reaching the full remission, should we taper down the dose? The previous studies talked about can we stop it or no, but this study showing us, is it possible to reduce the dose of certolizumab, and is there any relation between the gender, age, or subpopulation in terms of sustaining the remission? So the question here, the study here is about C-Optimize. It's a 2-part phase 3 trial demonstrated that certolizumab peak oil maintenance dose can be reduced in patients with spondyloarthritis. So this is a study design. If you look to the inclusion criteria here, they included the patient less than 45 of age with 3 months of back pain with active disease, ASDAS more than 2.1 and the BASDAI more than 4 with spinal pain, and previously the patient failed at least 2 NSAID. So at the week 0, you see here we have 736 patients. The patient had the loading dose, and the patient received the full dose of certolizumab, standard dose 200 milligram every 2 weeks. At the week 48, the patient assessed for sustained remission, and the sustained remission defined with ASDAS less than 1.3. So at this stage, week 48, we had 313 patients with full remission. The patient then randomized for 3 arms, either to receive the placebo or to receive certolizumab 200 milligram monthly, which is half of the usual dose or standard dose. The third arm received the full dose of certolizumab. Any patient flare during this, out of this arm, will be again included in the full dose of certolizumab. The flare was defined with ASDAS more than 2.1, and let's go for the result. So between the week 48 and week 96, if you look here, we are comparing the patient receiving the full dose with patient receiving the half dose. I think it's very comparable, and it's much superior to the placebo. Out of this paragraph, we see the patient on placebo, definitely most of them flared up, but the patient with half dose sustained remission with good rate comparable with patient with full dose. It's same for the male and female in this slide, and even the age showed no significant changes in terms of sustained remission. So patients less than 32-year-old and more than 32 sustained almost same remission on both full dose and half dose. So the conclusion here, certolizumab may reduce in the patient to achieve the full remission, and the reduced certolizumab maintenance dose appear to be feasible once sustained remission has been achieved, regardless of age, gender, or subpopulation. So again, complete treatment withdrawal is not recommended. So we have in this study now confirming the idea of we can taper down the dose down to the half of the standard dose, but stopping or withdrawal the medication is not an option. Okay, so now I will move to the third presentation or third trial. As you know that we have the family of IL-17, and we have two of them now approved for spondyloarthritis. We have secukinumab and TALS or the TALS. But now we have the new member, so we should welcome the bimekizumab as a third or fourth, actually, because we have third one, brodalumab on the psoriasis. But this one, the study showed the efficacy of the bimekizumab on the ankylosing spondylitis. So it is randomized, double-blind, phase 2 trials. So just a quick revision, what about the bimekizumab? It is a monoclonal antibody that neutralizes both IL-17A and IL-17F. So in this study, they studied this molecule only on ankylosing spondylitis, and they did not include non-radiographic spondyloarthritis. And they looked at the safety and efficacy at 48 weeks. So let us just look quickly here to the study of the design. They had 303 patients more than age of 18 ankylosing spondylitis meeting the criteria of modified New York criteria, which is ankylosing spondylitis criteria, and the patient have high BASDAI and failed NSAIDs. So the 303 patients were randomized blindly on the 5 arms, either placebo, bimekizumab 16 milligram monthly, 64 milligram monthly, or the standard doses 160 monthly and 320 monthly. And at the week 12, again, the patient with first 3 arms were randomized again into the standard dose 160 milligram monthly and 320. So if we look to the basic characteristic feature, it looks comparable, and this is the result and efficacy on this molecule in terms of the BASDAI. The first 2 small doses didn't show any efficacy, but the patient after switch to the full dose, which is either 160 or 320 monthly, showed good reduction in the BASDAI with significant improvement, and both doses 160 and 320 showed same efficacy in terms of reduction in the BASDAI, the BAS-Phi, spinal pain, again on the fatigue. And as we know that fatigue is a major problem in rheumatoid arthritis and ankylosing spondylitis, and we have limited data on the efficacy, and there is some report showed many of the anti-TNF is not helping the fatigue. But out of this trial, at the week 48, we see that the new molecule showed good efficacy in terms of fatigue and the morning stiffness. Again, both doses are same level of improvement. Sleep disturbance showed improvement, And again, the quality of life and SF36 again showed good improvement. On the safety part, I think it's very comparable to other IL-17. The nasopharyngitis was the most common side effect, as you know, and there was two major adverse events, which is cardiac, but it looks not related to the drug. So to conclude in this study, over 48 weeks of bictegravir, at week 12, improvement were greater in the patient treated with a full dose comparing with placebo, and we showed that the 160 milligram is equal efficacy to 320, and at the week 48, improvement were similar for both patients with no unexpected safety findings. So we expected this molecule to join the IL-17 family soon. Okay, so the other presentation I will move now. It's a bit of basic presentation. As you know that we have a lot of study about ankylosing spondylitis, spinal deformity and progression, but we have limited data on non-radiographic spondyloarthritis. And as you know, there is the question that is sacroiliitis damage may predict the spine deformity or not. So the objectives of this study to compare spinal radiographic progression in both non-radiographic spondyloarthritis and ankylosing spondylitis over the period of 2 years, and to investigate whether the sacroiliac structure damage predisposed to spinal progression. Going back for ankylosing spondylitis, we know that previous spine damage, increase in CRP, male-6 and HLA-B20 positivity and smoking are predictor for spinal damage. So now we are looking for non-radiographic spondyloarthritis. Again, the old data from previous cohort showed the radiographic spondyloarthritis progressed within range of 1 MSAS every 2 years, comparing with half and 0.1 MSAS score every 2 years out of DESIRE and GISPEC cohort. So the inclusion criteria here, they included the patient with non-radiographic spondyloarthritis with 2 sets of spinal radiographs within 2 years time, and they excluded the patient with spinal ankylosis. Okay, so looking for the result, we had about 88 patients with non-radiographic spondyloarthritis and 418 patients with radiographic spondyloarthritis, and we had about 725 radiographic images. And the result showed that, again, patients with non-radiographic spondyloarthritis progressed with a rate of 0.16 every 2 years, comparing with 0.92 units of MSAS every year in patients with radiographic spondyloarthritis or ankylosing arthritis. So again, they found the sacroiliitis or sacroiliac joint damage predict the possibility or increase the possibility of spinal deformity and changes. Again, as we know before, baselines and dysmorphite were predictors for further progression. So again, ankylosing spondylitis progressed more than non-radiographic spondyloarthritis, maybe 4 times more, and the spinal damage is mostly restricted to the patient with radiographic sacroiliitis. And again, as you know before, smoking and baseline damage and possibility of HLA-B27 could increase the risk of spinal deformity. So saving time, I will go now for the study number 4, which is maybe giving us a hint how fast should we move and treat our patient in order to prevent further damage in the spine. This study was designed with special designing. We will see it together now. You know the basics before that osteitis and inflammation will lead to fat lesion, and then the fat lesion may cause the new bone formation or syndesmophyte. So the question here is, does the presence of active inflammation increasing the risk of fat lesion, and does early resolution or improvement of active inflammation mitigate the development of fat lesion in spine or not? So this study, which is a rapid study, which is well known as a phase 3 randomized double-blind study in certolizumab, we are not concerning much about the upper part, but looking down for the patient whom had MRI set at the baseline and at least one more MRI during the study until we reach the week number 204. So we had 136 patients had the MRI at the baseline, and then they randomized either to receive the placebo or the full dose of certolizumab. So at the end of that week 204, we have 23 patients reach the area of placebo, and they continue the trials, comparing with 55 patients with full dose of certolizumab. The MRI was scored blindly with two central reader to evaluate the MRI T1 and stare looking for the vertebral edge. So here, if you look at the result, at the baseline on the left side, we have about 80% with no inflammatory lesion. And we have about 20% of the patient with inflammatory lesion. So out of this 80 with inflammatory lesion, without inflammatory lesion, only quarter of them, or 25%, had fat lesion. And out of this 20 with inflammatory lesion, 50% had fatty lesion. So this indicates presence of inflammation increasing the risk greatly in terms of fat lesion formation. And the most of the patients without inflammatory lesion had no fat lesion. The mean count of the inflammatory lesion per patient was about 5. After 12 weeks of treatment with full dose, if we look here, before it was about 80 with inflammatory lesion, now we have 88% with no inflammatory lesion, and only 12% of the patients they had inflammatory lesion. The most important is the mean count of the inflammatory lesion is only 2.7. So if we look here, we find the patient with no baseline inflammation had very low risk of developing the fat lesion, comparing with the patient with baseline inflammation. And we see here, comparing week 12 to week 204, there were slowly progressive increase in the fatty lesion, and that means we have higher risk of fat lesion and forming of syndesmophyte, so this will end with spinal deformity and limiting the movement of the spine. So the point here and conclusion here, the first report clinical interventional placebo-controlled trial to show how the inflammation prevailing after the start of TNF treatment, if the inflammation continue, this will increase the lesion up to 4 years. And if we have reduced the inflammation by week 12, that mitigate the fat lesion risk, and we may protect the spine. So that means maybe we have to move as soon as possible if the patient failed the NSAID, trying to stop the inflammation. Then in turn, we will have less fatty lesion, and hopefully we will prevent syndesmophyte formation. Now I will move to this the fifth trial. This is the area of debate since long time. We have seen a lot of patients with spondyloarthritis, mainly axial spondyloarthritis, still on steroid. So the question is, do you think steroid, in case if you are unable to start anti-TNF or IL-17, will help the axial spinal or no? So we know that local steroid is recommended locally, even for the sacroiliac joint, but systemic steroid is not recommended. So this trial was conducted in India to evaluate the efficacy and safety of step-down regimen of oral prednisolone over 24 weeks in patients with axial spondyloarthritis. It was double-blinded study, saving time. I will not go through the inclusion criteria. It is the patient meeting the ESASI criteria 2009. So let's go for the designing. They divided the patient on 1-to-1 blinded for either to receive placebo versus prednisolone. The patient were on prednisolone started with 60 milligram week number 1, then 14 week number 2, down to 30, 20, 15, 10, until they reach week 7. They kept the patient in 5 milligram until the week 24. They look for the BAS-DI, BAS-FI, and BAS-ME, and then we will see the result. So they started with 60 milligram down to 5 milligram over 7 weeks. Then they kept the patient for about 17 weeks on 5 milligram. So the primary outcome was achieving PAS-D 50, and the secondary outcome were the PAS-Phi, PAS-D, PAS-Me, and the others. So saving again time, we had about 30 patients randomized to steroid and 33 patients for placebo. At the end of the trial, about 30 patients on each arm completed the study, and the basic demographics were comparable, except the patient with prednisolone showed higher CRP. So this is the primary outcome. We have about 38% of the patient on prednisolone reached PAS-D 50, comparing with 9% only patient on placebo, and this was significant. And again, on terms of the PAS-DI and the ASDAS CRP and ASDAS ESR, the patient on prednisolone showed improvement. So the interesting point here, at week 12, the patient showed no improvement. The improvement only appeared at week 24 of prednisolone. So in terms of the side effect, there was no major side effect, only facial puffiness and cushingoid appearance, which is very expected, and weight gain. So what we conclude here, that definitely the study showed sample, but size was very small, and there is very limited number of studies, and there is no evaluation of the MRI changes or X-ray changes over these weeks. So we do not know the efficacy of prednisolone in terms of reducing the inflammation truly in the MRI and reduce the risk of deformities. But just keep in your mind, if you have the patient, for example, with malignancy, multiple sclerosis, and we are unable to reach one of the biologic, maybe prednisolone could be one of the options, but I believe it will be at the bottom of the list, and we have to be very careful with this treatment for axial spondyloarthritis. Okay, so now I will move for the other study, and we know that the long question, we have it long time ago, should we combine the biologic therapy with conventional DMARD in area of increase the survival, and can we combine them just as a synergistic effect, trying to save our biologic therapy retention? So this study was conducted in Europe. I will not go through a lot of the objectives here. Let's move to the methods. We have about 13 European registries were included in this study. Hopefully at one area we will have at least 5 or 6 Gulf or Arabic registry to conduct studies together. So what they did, they divide the patient either to receive TNF as a monotherapy alone, or to combine the biologics with conventional DMARD. Actually, there is no clear conventional DMARD dose. Is it methotrexate, sulfasalazine, or other? But we have two arms, either a monotherapy or combo therapy with conventional DMARDs. So if we look to the study at all, about 80% of the patient with combo therapy retained the biologics at week 50. Comparing with only 78, and according to the statistics, the p-value was significant. So they said in conclusion that the patient on the combo therapy showed higher retention. And very interesting here, if you look after they divided the study result in terms of countries, we look few countries here, like Spain and other, showed the monotherapy was superior. And if we look to the group number B, countries number B, the combo therapy retained the medication up to 77%, comparing only with 72 on the monotherapy. This is very confusing. If we have European people or European study out of 16 or 17 registry, and they showed in the previous slide good retention on the combo therapy, but when they divided in terms of countries, the monotherapy in these countries showed superiority in terms of retention comparing with group number B. So I will not conclude here anything, because actually we don't know. A study was conflicting. We have all data showing that infliximab specifically showed higher efficacy and more survival with combo therapy or synergistic effect of conventional DMARD, and this study showed no clear conclusion about the combination with conventional DMARD. But I think we need more study in terms of retention. There is no clear point to reach out of this study. Moving to secukinumab, 150 milligram. This study, we know that secukinumab is approved, but what I found the tricky point here in this study, the loading dose. Maybe the benefit is knowing now, should we load our patient 5 weeks with secukinumab before we go for the maintenance therapy, or we should go with just regular dose? We can find it out of this study. This is a PREVENT study, is a phase 3 randomized placebo trial. Saving time, I will show you what is the design here. We have the patient randomized either to loading with secukinumab or no load or placebo with average number of 180 in each arm, and then they did the analysis at week 16 and week 52. So going to primary result, I will show you the result here. At the end of week 52, if you look at the patient without loading, the light blue was almost comparable, if not superior, to the patient with loading dose. This is much significant result comparing with the placebo, but if you compare both of the loading and without loading, I think we got the same benefit at the week of 52. Maybe the patient with loading here, if you look to the first 16 weeks, showed higher efficacy. So again here, for BAS-DAI 50 and ASDAS CRP, the patient with loading was comparable and maybe superior to the patient without loading. This is same for the MRI reduction. I think we have now the idea of, can we consider secukinumab without loading, and we may get a bit of delay before the reaching our target, but at least we may save a lot of money and we may decrease the risk of the side effect if we avoid the loading. Okay, so the other slide, because we are
Dr. Mohammed,
yes.
لو سمحت, we cut time already.
So can I keep or stop?
If we could wrap up, please. If you could just pass it quickly.
Sure.
Appreciate that. Thank you.
Okay, so this is a huge study done on the impact of spondyloarthritis and ankylosing spondylitis. The point I presented this study that we keep thinking about the pain, deformity, and we are helping the patient with the stiffness and fatigue, but we should think about sexual impact, especially with patient complaining of some psychological depression or impairment because of this issue. So the conclusion of this study, it showed great impact up to 75% on terms of sexual functionality. So we should think about our patient to include them in the physiotherapy and assessing the patient with psychological support in this matter. So the other question, the other trial is very important in terms, we have a lot of questions, especially the female patient. I have ankylosing spondylitis. Am I at risk of having the patient with ankylosing spondylitis or patient deformity or so on? Is it safe to get pregnant comparing with other normal female? So this is the study from Korea. It's out of 2 cohorts, and the result, just I will show you the conclusion. There were a bit of increased risk of cesarean section and preeclampsia comparing to a patient with a non-ankylosing spondylitis, but the growth development of children with AS mother was totally comparable with patient with no ankylosing spondylitis. So we believe, inshallah, in our offspring will be fine with no complication comparing both ankylosing and non-ankylosing patient children. This last one, I will finish with this one. We know the question about certolizumab or secukinumab, sorry. Do we have any evidence that secukinumab may help the anterior uveitis? This is a study comparing secukinumab, adalimumab, infliximab, and etanercept in terms of new episode of anterior uveitis while the patient on treatment as a naive first treatment, and they concluded that secukinumab and etanercept are associated with higher incidence of anterior uveitis comparing with adalimumab and infliximab. So the data showed in this study no much protection of anterior uveitis when you are treating your patient with secukinumab. I need to finish here. Thank you very much, everyone. Thank you, Prof. Suzanne, and I leave the floor for my colleague, Dr. Ziad. Thank you.
Thank you, Dr. Mohammed, for this excellent and detailed presentation. We learned a lot today, and inshallah, we will consolidate our information more. I would like to present our next speaker, who is Dr. Ziad Al-Zahrani, Dr. Ziad is a consultant rheumatology at King Abdulaziz Medical City. He's an associate professor at King Saud bin Abdulaziz Health Specialist in Jeddah. He have a Master of Medical Education and Diploma in Epidemiology and Biostatistics. He's a formal section head of rheumatology and the formal member of the Saudi Rheumatology Association. Dr. Ziad will talk to us today about psoriatic arthritis, and he will present the latest update and the abstracts that have been presented at the EULAR. Dr. Ziad, the mic is yours, please.
Thanks, Prof. Suzanne, for this nice introductions. And my talk is going to focus on psoriatic arthritis. And I will be actually presenting some of the important presentations in the latest EULAR 2020 that may have an impact in clinical practice. So if you look into the agenda that I'm going to discuss today, I'll be talking about the control study, which is addressing the adalimumab introduction versus methotrexate dose escalation in patients with inadequately controlled psoriatic arthritis. And then I'll be talking about the secukinumab, which is actually maybe the first study to assess the value of secukinumab in patients who have axial manifestations of psoriatic arthritis. And then I'll be talking about guselkumab, which is, of course, interleukin 23b19 subunit inhibitor, again, in the axial involvement in patients with active psoriatic arthritis with imaging confirmed sacroiliitis. And then I will be talking also about the JAK inhibitor, JAK1 inhibitor, upadacitinib, in the SELECT PSA study in the setting of active psoriatic arthritis. And then I will be talking about another two important studies, which is head-to-head trial in psoriatic arthritis. This is what we are looking for to see actually more. Head-to-head trials between secukinumab and adalimumab in psoriatic arthritis. We have seen actually the skin psoriasis head-to-head trials, but now we are seeing the psoriatic arthritis head-to-head trials, including also the ixekizumab versus adalimumab, the SPIRIT head-to-head trial in patients with active psoriatic arthritis. So without further ado, I'll start for the first study, which is assessing actually the adalimumab introduction versus methotrexate dose escalation in patients with inadequately controlled psoriatic arthritis. And this is result from the randomized phase 4 control study. If you look into the objective of this control study was to compare actually the achievement of minimal disease activity, which is a high bar, at week 16 between adding TNF inhibitor adalimumab versus escalating methotrexate dose. And you can see here the study design where you have about 246 patients were randomized to adalimumab versus methotrexate escalated dose to the maximum or highest tolerable dose. And if you look into this study, for example, the mean dose of methotrexate was 21.8, which is really high. More than 85% of the patient were having a dose more than 20 milligrams, which is really a great dose in the setting of psoriatic arthritis. And this study, I'm going to report actually the results at week 16, but it's going to be ongoing also, and probably the results will be seen in the future. Now, if you look into the results, the primary endpoint, as we mentioned, is the minimal disease activity at week 16. And here you can see without doubt that significantly higher proportion of the patients in the adalimumab plus methotrexate fixed dose, 50 milligram, versus the escalated methotrexate group achieved minimal disease activity at week 16. So talking about 41.5% in favor of adalimumab versus escalated dose of methotrexate. Now, if you look into the stratification by the prior methotrexate duration, the adalimumab was also shown to be statistically significant in whether the patient is having more than 3 months or less than 3 months. But if you see the methotrexate patients or the patients who are taking methotrexate more than 3 months had better actually responses, which is expected because we know that methotrexate takes longer to kick in. Now, if you look into the other endpoints, including basically the MDA over time, you would see that separation, statistically significant separation, occurred at week actually 4 and continued over the duration of the study. If you look into the SS 20, 50, and 70, again, this demonstrates that adalimumab is superior. This is really different than what we see in rheumatoid arthritis, as you know. We see that adalimumab is definitely superior when it combined to a fixed dose of methotrexate to escalated dose of methotrexate in all end results here, like the ACR 20, 50, and 70. If you look into the skin manifestations, again, adalimumab was statistically superior in comparison to the escalated doses, and also in the function, a better function was seen in patients with adalimumab in a statistically significant fashion. And also the enthesitis measured by the Leeds Enthesitis Index and bilateral plantar fasciitis, you would notice that adalimumab was statistically significant in this result. Right, now let's go here and talk about the conclusions of this study. A significantly higher proportion of the patient achieved NDA at week 16 after actually introducing adalimumab, and higher MDA rates in the adalimumab plus methotrexate arm were observed, regardless of prior methotrexate duration, as we have shown you. Higher responses in the musculoskeletal, in the skin, and the quality of life measures were observed with adalimumab plus methotrexate versus escalated methotrexate, and the safety results in the study were consistent in the known safety profile of adalimumab. The control study is still ongoing, and we will see actually the long-term study in the future. Now let's go and talk about here the secukinumab, actually a study which improves the clinical and imaging outcomes in patients with psoriatic arthritis in the MAXIMIZE trial, and we said this is the first trial to assess the response of secukinumab in the axial manifestations of psoriatic arthritis. And if you look into the objectives of the study is to present the 52 weeks efficacy results and imaging data from the MAXIMIZE trial. Now, this is the study design. You could see that we have three groups. We have the secukinumab 300 milligrams with a loading dose, and you have also the 150 milligrams of secukinumab with a loading dose, and you have the placebo. And you can see the results were at week 12. This is the primary endpoint at week 12, and then at week 52, we're going to see the results again. Now, let's see the the baseline and demographics and disease characteristics. They are actually evenly distributed between the groups. However, if you look into those patients who have back pain worsening with rest, almost more than 90% of the patient had this kind of criteria for inflammatory back pain, and even awakening due to back pain more in the second half of life, more than 85% of those patients had it. So the vast majority of the patients had one or more of these criteria for inflammatory back pain. If you look into the secukinumab sustained ACR 20 and 40 responses through week 52, because I think you have already seen the result for the primary endpoint at week 12, which you can see that there is statistically significant result in favor for the both doses of secukinumab, and they do seem to be overlapping, like the 300 and 150, they do not seem to make a difference in terms of the response of the SS20, but it's definitely superior to the placebo. Now, if those patients who are in the placebo group, when they were re-randomized to secukinumab, they have picked up in terms of the result, and you can see at 52 weeks, there's actually significant, there are good responses over time. And the same thing goes for the SS40. Now, if you look into the secukinumab and the Berlin MRI scores, it was found that the Berlin MRI scores were reduced in the groups of secukinumab compared to the placebo. And even when you look into the entire Berlin score for the entire spine and also for the sacroiliac joint. So we have definitely significant improvement in the secukinumab arms compared to the placebo. Now, if you look into over 52, the same thing, significant reductions for the changes in those patients with secukinumab. Now, let's look into the conclusions here. Secukinumab provided significant improvement in the signs and symptoms and the objective signs of inflammation of axial disease in patients with psoriatic arthritis with axial manifestations and inadequate response to NSAIDs. And results of the MAXIMIZE trial provide valuable data that will support ASAS and GRABA efforts to deepen the clinical understanding of axial spondyloarthritis in those patients with psoriatic arthritis. So the safety profile of secukinumab was consistent with previous reports. Now let's look into this study, which is assessing the guselkumab, which is a interleukin-23b19 subunit inhibitor in those patients who have axial involvement in patients with active psoriatic arthritis with imaging confirmed sacroiliitis. This is a week 24 result from 2 phase 3 randomized trial, which is the Discover 1 and 2. So the objectives of this study was to evaluate the efficacy of guselkumab, in psoriatic arthritis patients with imaging confirmed axial involvement consistent with sacroiliitis in the Discover 1 and 2. So this is a post hoc analysis from the both Discover 1 and 2 studies, and you have to take it always with a grain of salt when it is a post hoc analysis. Now, this is the study design. You can see that there are 3 groups here, the guselkumab 100 milligrams, and then they are going to be given every 4 weeks. And then the guselkumab 100 milligrams subcutaneously, and then they will be given every 4 weeks. And you have the placebo up to week 24, and the patients, when they reach 24, they will be re-randomized to receive guselkumab 100 milligrams at every 4 weeks. So let's look into the baseline demographic and disease characteristics were more or less similar between the 2 groups. However, what you can see here, probably I can point out that 2/3 of the patients had actually the HLA-B27 tested among them, and almost 1/3, you could see almost 1/3 of the patients had positive HLA-B27. Now, a greater improvement in the BASDAI-related endpoints in guselkumab versus placebo were demonstrated, as you can see here, for the both doses, and they seem both doses are similar. I mean, if we give it every 4 weeks or every 8 weeks, there's no much difference really. So probably it's better to stick to the 100 milligrams every 4 weeks. But it's definitely statistically significant compared to the placebo, both in the BASDAI and the spinal vein, and also in the modified BASDAI, where they removed question number 3, that is dealing with the peripheral arthritis. So we have a statistically significant result in favor of guselkumab in this patients' populations. Again, the same thing was noted, greater improvement in the ASDAS-related endpoints in guselkumab versus placebo at week 24. And in fact, even at higher bars like ASDAS major improvement more than or equal to 2 points, you still see a statistically significant result in favor of guselkumab versus placebo, and also in the ASDAS inactive disease. Higher results, 53 to 57 compared to almost 28% in the ASDAS placebo group. Okay, now if we look into the BASDAI-related endpoints, whether those patients had HLA-B27 or positive or negative, they still respond, and you can see here the same things in the 2 groups. The same thing was demonstrated for the ASDAS-related endpoints. The patient improves whether they are HLA-B27 positive or negative. So in conclusions, the guselkumab 100 milligrams every 4 weeks or every 8 weeks improved the axial symptoms over 24 weeks in the active psoriatic arthritis patient with reported radiographic sacroiliitis. And as measured by the BASDAI and ASDAS-related endpoints, improvements in the axial symptoms were observed irrespective of the HLA-B27 status, as we have mentioned. Now let's look into the update on new treatment options for psoriatic arthritis, and definitely we're going to talk now about upadacitinib, which is a JAK1 inhibitor, as you know, in patients with active psoriatic arthritis with inadequate response to biologic disease-modifying anti-rheumatic drugs. I think you know the SELECT-PsA2, which is dealing with inadequate response to biologic disease, but if you look into the SELECT-PsA1, it is in those patients who have inadequate conventional synthetic DMARDs, and which was already published. Now, if you look into the upadacitinib objectives here, is to assess the efficacy and the safety of upadacitinib versus placebo in patients with psoriatic arthritis and prior inadequate response or intolerance to one or more biologic DMARD. So if you look into here, this is the study design. We have actually 4 groups. In fact, a good number of patients were randomized into 4 groups: the upadacitinib 15 milligrams or upadacitinib 30 milligrams. You can see 211, 219, and then the placebo, 2 placebos. And the idea is that one placebo is going to be re-randomized to 15 milligrams, and the other placebo is going to be re-randomized to 30 milligrams. And this is the randomization was 2 to 2 and 1 and 1. And the idea is that they wanted to have more patients to be given an active drug, and at the same time to have more power in these arms. So if you look, and this is acceptable type of randomization. Now, if you look into the inclusion criteria, it's actually the usual type of randomization. Those patients are still having active disease, psoriatic arthritis, demonstrated by more tender and swollen joint count, as you can see here. Now, let's look into the baseline demographics and disease characteristics. And what you can see here, they are evenly distributed across the arms. And you can notice actually here about 30% of the patient had more, 2 or more biologic inadequate responders. So they are really having bad disease. They did not respond as good. So let's look into the, and this is the same thing basically for the characteristics showing you that the patients are having active disease. If you look into the tender joint count and swollen joint counts, they are really high. Okay, now let's look into the patient disposition. You can see we have 642 patients randomized, and almost 80% in the placebo arm were able to continue the study drug up to 24, and almost 85% or more in the upadacitinib completed the 24 weeks. So good percentages. Now, if you look into the efficacy endpoints in this study, we have the ACR 20 as the primary endpoint, but we do have multiplicity controlled secondary endpoints, as you can see here, a lot of them, including the ACR 50, 70, and others. Now, if you look into the responses at week 24, so the ACR response at week 12 here, and then for the ACR 20, we have a statistically significant proportion of the patient achieving ACR 20, something in the range of 64 for the higher dose and 57 for 50 milligrams upadacitinib versus 24 in the placebo. If you look into higher bars like the ACR 50, we have 38% of the patients in the 30 milligrams achieved statistically significant result compared to or versus placebo, and the same thing for upadacitinib. If you look into the ACR 70, which is a higher bar, almost 17% in the 30 milligrams and 9% in the 50 milligram upadacitinib achieved the ACR 70 compared to only 1% in the placebo. And remember, those patients, about 1/3 of them, they failed 2 or more biologic. Now, let's look into the response through week 24. And you can see that we have sustained response across this 24-week duration for all these parameters. If you look into resolution of enthesitis and dactylitis at week 24, we do see that the patient achieved actually statistically significant result in favor of upadacitinib versus placebo. We're talking about 45% in the Leeds enthesitis index and versus only 15%. And if you look into the Leeds dactylitis index, we are seeing almost 58% in the 50 milligrams versus 28% in the placebo. So we do still have actually significant results in both enthesitis and dactylitis. If you look into the BASI response at week 16, and we still actually see, these are the skin manifestations, and we see statistically significant results again across all BASI responses, whether 75, 90, or 100 in favor of upadacitinib, and it's really significant. Now let's look into the proportion of the patient achieving minimal disease activity. You know, this is a composite measure which is including a lot of parameters, including the arthritis and the skin and many others, including the patient's pain. So we do see that there's statistically significant actually results. I think someone is opening the mic. Mr. Khalid, can you close it, please? All right, so the proportion of patients achieving the MDA at week 24 was shown to be statistically significant in favor of upadacitinib, 25% in the upadacitinib 50 milligram and 29% in the 30 milligrams versus only 3% in the placebo. Right, so if you look into the treatment emergent adverse events through week 24, I think they are more or less similar to what we know about these drugs. Probably more adverse events in the upadacitinib 30 milligrams compared to the other, to the 50 milligrams and placebo. And if you look into the, for example, herpes zoster, definitely more in the upadacitinib 30 milligrams compared to placebo. And if you look into the non-fatal myocardial infarctions and pulmonary embolism, only one patient in the 50 milligrams, and some of those patients had risk factors for its development. So we do not see really any signal other than what we know from the previous studies. So in conclusions, for this select PSA2 study, upadacitinib versus placebo, we see that in this biologically defined inadequate response PSA populations, upadacitinib 50 milligrams and 30 milligrams demonstrated significant improvements across the PSA domains, and this includes improvement in the joint and the skin signs and symptoms versus placebo. through week 24, and a greater percentage of the patient treated with upadacitinib achieved MDA and other stringent parameters. No new safety signals were identified. Okay, now let's go for the head-to-head trials, which is really interesting in the setting of psoriatic arthritis. And we see that this is the EXCEED study, which is comparing the secukinumab versus adalimumab in the patients with in biologic naive patient with active psoriatic arthritis through 52 weeks, a randomized double-blind phase 3 study. And you can see that secukinumab, we know that it's an interleukin-17 inhibitor and has demonstrated improvement on multiple domains of psoriatic arthritis. And we have seen also head-to-head trials in skin psoriasis where interleukin-17 were superior to adalimumab in that setting. Now, this study is trying to report the efficacy and the safety outcomes from the head-to-head EXCEED trial that compares secukinumab versus adalimumab as first-line biologic monotherapy through 52 weeks with a musculoskeletal primary endpoint. So we are assessing the psoriatic arthritis head-to-head trial between secukinumab and adalimumab. So if you look into the study design here, we have two arms. We have the secukinumab 100 milligrams, and we have the adalimumab 40 milligrams. And you can see here the primary efficacy endpoint was at week 52. And then you have to go, if you achieve this primary endpoint, then you go for the secondary endpoints, because this is a statistical hierarchical order, which means that if you fail actually in the primary endpoint, you should ideally not go for the secondary endpoints, but we'll see you what happened. Now, let's go here. If you look into the primary endpoint, which is ACR20 response up to week 52, in fact, the ACR20 missed significance for secukinumab. So we see that the results more or less are comparable. In the for example, secukinumab achieved 67% ACR20 at week 52 compared to only to 62% in the adalimumab. I think there were more ambitions to see if secukinumab would be superior, but it did not turn out to be the case in the setting of psoriatic arthritis. Now, as we said, it's not formal to test for secondary endpoints if you had primary endpoint failure, because it's a statistical hierarchical type of study. But here they did this non-formal testing, which shows you, if you look into the BASI 90, which is the skin parameter, you would notice that the secukinumab achieved almost 65% versus 43%, numerically higher percentage. And even if you test for superiority, it is there. We know this even from previous studies. If you look into the ACR50 response, again, there is no difference between secukinumab and adalimumab. Right. If you look into this kind of concept, which is the simultaneous ACR50 and BASI 100 responses up to week 52, we do see that secukinumab was statistically significant compared to the adalimumab. And if you look into this, study discontinuation curve by Kaplan-Meier, showed a statistically significant result in favor of more retention for secukinumab compared to adalimumab. So you can see about 14% difference between the two drugs. Now, if you look into the serious adverse events and other side effects, they are more or less similar between the groups. Maybe a little bit increased injection site reactions in the adalimumab group compared to the secukinumab. So in conclusions, secukinumab missed statistical significance for superiority versus adalimumab in the primary endpoint of ACR20 response at week 52. And secukinumab provided numerically higher clinical responses across musculoskeletal, skin endpoints and composite indices at week 52. Secukinumab was associated with a higher retention rate, and safety profiles was similar from what we know from previous studies. And the results suggest that secukinumab is at least as efficacious as adalimumab on the musculoskeletal endpoints.
Dr. Ziad?
Yes?
Please, could you wrap up?
Yes, I'm even behind time. I started at 27. I'm still having, but anyhow, I will finish. This is the last. This is the last actually one. Anyhow, we can see that ixekizumab, again, it's interleukin-17 in psoriatic arthritis head-to-head trial between adalimumab. The difference is that this one is an open-label study with blinded assessor, and you can see that the result here, the ixekizumab versus adalimumab, as we have mentioned. And if you look into, I'm reporting actually the 52 weeks, because actually the 24 weeks has already been reported in the previous 2019 EULAR. You can see here the monotherapy and with concomitant conventional synthetic DMARDs and concomitant methotrexate, percentage of the patient achieving simultaneous ACR50 and BASI 100 was superior in favor of ixekizumab than adalimumab. And in fact, it seems that adding conventional synthetic DMARD does not improve the result of ixekizumab, but it does really improve the result of adalimumab. Now, let's go and talk about quickly the percentage of the patient achieving BASI 100. You will see that ixekizumab was superior, whether monotherapy or even the combination with conventional synthetic DMARDs. But you can see also that adalimumab, the combination with conventional synthetic DMARDs and methotrexate, was shown to be better, but it does not affect the ixekizumab. Again, the things for the ACR50, we see no much difference in terms of the ACR50 responses. And if you look into the DAPSA, we have statistically significant result in favor of ixekizumab in the monotherapy, but not in the combined therapy with the conventional synthetic DMARDs. And again, the same thing for minimal disease activity. It was, ixekizumab was statistically significant in the monotherapy, but when you add adalimumab when you add the conventional synthetic DMARDs, the adalimumab results improves. So there's no statistically difference in the combinations. Right. If you look into the percentage of the patient achieving Leeds enthesitis index and dactylitis, they are similar between the two drugs with no differences. And in conclusions, the efficacy of ixekizumab was sustained until week 52 in the SPIRIT head-to-head trial, with consistent difference from adalimumab in terms of combined ACR50 and BASI 100 in point, in line with the data observed at week 24. The safety results were consistent with the known safety profile of both drugs. Adalimumab was associated with numerically lower response rates when used as monotherapy than in combination with conventional synthetic DMARDs. The efficacy of ixekizumab was similar regardless of whether it was taken as monotherapy or in combination with conventional synthetic DMARDs. And results from the subset of patients taking methotrexate at baseline were consistent with those of the broader conventional synthetic DMARD groups. So with this, I end my talk, and thanks. I think I started actually at maybe 9:30, and I'm even before the time. So thanks a lot.
Thank you so much, Dr. Ziad, for this formal presentation. We have 5 minutes for questions, and we already have a couple of questions have been going on since Dr. Badawi finished his presentation. There is an important question with regard to the tapering of the Enbrel with regards to the re-embark trial. Now, does it make a difference when we talk about tapering of the Enbrel or the anti-TNF if we space the drug versus decreasing the dose?
Thank you, Dr. Prof. Suzanne. Actually, we don't know. There is no clear guidelines or recommendation. We don't know when to start to taper. If the patient, definitely we will not start tapering unless the patient achieving the full remission. So the question, when should we start tapering down the dose? Is it after 6 months? After 1 year? As I presented now, maybe 6 months is the minimum for certolizumab to start tapering the dose. The other question, how to decrease the dose? Should we space it up, increase the duration, or should we decrease the dose? Maybe it's same, maybe it's not, but we don't have data on that. Maybe safely, I'd say safely to decrease the dose if possible, like on certolizumab. But if we cannot, like for example, for etanercept, we cannot divide it, or Humira, for example. So maybe we would increase the frequency, decrease the frequency, or increase the duration between the doses. Still, we don't have data. Definitely, stopping the medication is not an option. So tapering maybe after 6 months minimum, safely at 1 year after full remission, either to decrease the dose or increase the duration. We don't have data, but maybe decrease the dose if possible, or increase the duration if you cannot decrease the dose.
Excellent. Now, the second question is with regard to the study of the prednisolone for Axel SPA. Now, for the patient who failed treatment, they were having persistent high inflammatory marker, i.e. high CRP. Now, do you think that the effect of the unresponse to the steroid is the persistent high CRP, which
Actually,
indicate an active inflammation and so erosions?
Actually, if you look to the demographics, the patient on the prednisolone arm showed higher CRP, and they respond by the week 24. So out of this study, I think the CRP, yes, is bad indicator. We know that increased the risk of deformity and progression, but the patient who on the prednisolone arm showed higher CRP and they showed good response at the week 24. So I think no relation between the CRP and response based on this study. So there is no limitation in this study in terms of the CRP high will decrease the response of prednisolone. The study showed even the patient with high CRP showed good response at 24 weeks of treatment of prednisolone. But again, this is not standard therapy. This is very unlikely situation to use prednisolone as a first line or even using the prednisolone for axial spondyloarthritis.
Now, there's another question, and I guess it's for both Dr. Badawi as well as Dr. Zahrani. Do you consider IL-17 inhibitor as a first-line treatment line for either ankylosing spondylitis or psoriatic arthritis?
Ziad?
Okay, if you want me to answer this question, I think even we have the EULAR guidance on this. I mean, in those patients for psoriatic arthritis, we're talking about psoriatic arthritis, the patients whom they have more skin manifestations, the interleukin-17 inhibitors would be preferable in these subsets of patients. However, as I've shown you in the both studies of ixekizumab and adalimumab, and also the secukinumab versus adalimumab, in terms of the musculoskeletal manifestation, they seem to be similar. There's no one more than the others in terms of the musculoskeletal manifestation. But really, again, I mean, if you have patients who have more of a skin manifestations, probably that's preferable. However, the anti-TNFs would be preferable in those patients who have like uveitis or who have inflammatory bowel disease. In this setting, I would really go for anti-TNF medications.
Okay. Dr. Badawi, do you have any comment about this?
Yes, from my side, maybe it's a bit different than Ziad because Ziad dealing with skin psoriasis. We know the result on secukinumab in terms of skin was superior. But when talking about spondyloarthritis with axial involvement, if you look to the ACR 2019, the most recent recommendation, they strongly recommended both of them, the anti-TNF and the IL-17. But still, they kept the anti-TNF as a first line, then the IL-17 the second line. But if you look what is behind this, there was no solid evidence that the anti-TNF is superior, but because of more experience. If you look to the details, they said because of more experience with anti-TNF, we prefer it over the IL-17. But if you ask my opinion, I think they are similar. Now we have good experience with both of them. The efficacy was good. And if you look to the data on naive patient, starting the IL-17, I think the result much better than the primary or secondary failure of anti-TNF. So I think they are now could be used as a first step, keeping in your mind ACR 2019 is recommendation, is not guidelines. So we do not have guidelines for spondyloarthritis. We have recommendations, and sometimes your guidelines is yourself and your patient. You can discuss it with your patient, and maybe on the need, maybe spondyloarthritis or psoriasis, maybe I will start secukinumab as a first line.
Sure. And we have another question for Dr. Ziad for psoriatic arthritis. If there is any head-to-head study between upadacitinib and tofacitinib for the treatment of psoriatic arthritis?
Unfortunately, there is not. Okay, so we do not have any head-to-head trials comparing the JAK inhibitors, but hopefully we have something in the future. But at this time, we do not.
Okay. So by this, I would conclude this session. I would like to thank both of the speakers. I would like to thank the Saudi Society for Rheumatology and for the audience. And inshallah, we will meet within the next time and go ahead for the third session. Thank you so much.
Thank you very much.